Remember that the left bundle branch is more convoluted because we've got the left bundle branch, and then we have the fascicles and the hemiblocks. I won't deal with hemiblocks today, but we will deal with them. So we've got the left bundle branch that can be blocked, or the independent fascicles can be blocked. I'm going to talk about right now what happens when the entire bundle branch gets blocked, which means the fascicles are wiped out. They're not part of the mix anymore. Okay? So we've got a block in there somewhere. That make sense? For the left side. Okay. So with that being the case, what kind of rhythm do we have to have?
Wide.
With
supraventricular, that's wide.
Supraventricular rhythm. We must have a supraventricular rhythm first, and then we notice that we've got a wide QRS complex. Point 1, 2 are great. So we have a wide QRS complex. Great. In the wide QRS complex, which lead would that show up in?
All of them.
All of them. Fantastic.
We wouldn't be able to see it in the biphasic.
You might have a hard time seeing it in the biphasic lead. That's true. And frankly, I only need to see it in one lead, because if it's wide in one lead, where else is it wide?
In all
Everywhere.
leads.
Good. Okay. Okay, so there's number one. Number two, we will see that most of the leads will show you monomorphic complexes. Most of the leads will show you monomorphic complexes. I want to key in on the same three leads, which are what?
1,
1,
5.
V1,
V6, and
V1.
V1. Those are the three leads I want you to key in here as well, which is great because those are the only leads you truly need between either of the bundle branch blocks. But in most of the leads, you'll see monomorphic complexes.
Could you tell me what monomorphic complexes
No, but
mean?
you can tell me. What does monomorphic mean?
One more.
Direction.
One morphology.
One
That's right.
morphology.
One
So-
morphology in the context of a QRS complex would mean what?
It only goes one direction.
That's right. So they're either all positive or all negative. They tend to be either all positive or all negative. They tend to be all positive in leads 1 and V6, and they're all negative in V1. And notice that V2 and V5 show up with those same leads sometimes. But leads 1 and V6 are all positive, and V1 is all negative. Good? Why? You should be able to answer that question. Why will they be all positive in leads 1 and V6 and all negative in V1?
The majority of electricity is going right
Never mind.
Straight.
No, say it, V.
There's more electrical activity on V1 and V6 rather than V1, because the electrical activity in V1 is going away from it,
Towards it.
towards the left.
V1.
Towards the left side.
Oh,
Okay,
V1,
so
away from it.
say that another way so I can understand it better. I think you have it.
So
But
in V1, the electrical activity is going to the left, more to the left.
in V1.
Yes,
And is that going towards it or away from it?
away from it.
Great. And what's happening on the right side?
What's happening on the right side?
Yeah.
It's still depolarizing,
Great.
It
but
happened
there's more
fast.
on the left.
Great. And then what's happening in the other leads?
Depolarizing.
Yes. What's happening in leads 1 and V6?
All the electrical activity is happening on that side, which
Going
is on the
in
left
what
side.
direction to them?
Down, towards it,
Towards it.
towards the,
Wait, did you say V1 and
I
V6?
said lead 1.
Lead 1 and V6. Okay,
Does
thank
that
you.
make sense what he was trying to explain?
no.
You didn't
It doesn't make sense to you?
No, it's in a roundabout way you thought it.
Lead 1 and V6 are right here, looking at the side of the heart.
Yeah.
Right? We have a left bundle branch block, so the majority of the electrical activity is happening on what side of the heart? On the left side.
Still left.
Yeah. How is the left side depolarizing right now?
Cell
Cell
to
to
cell.
cell.
So where is the average majority of the electrical activity in the heart happening?
On the left.
On the left side. So leads 1 and V6 are over here looking directly at the left side where all of the electrical activity is traveling. Right? Endocardium, epicardium, cell by cell, all towards the left, which means everything's going directly towards lead 1 and V6. That make sense? Because all of that electrical activity is happening towards them, And because the right side is so puny compared to the left side in terms of electrical window, the amount of electrical activity, it only really sees that left activity. So everything's really positive. V1 is right here. And it sees a little bit of that right electrical activity, and the right side is definitely depolarizing first, but most of the electrical activity and most of the time for the electrical activity is happening on the left side, and most of that is traveling this direction, which is away from where lead 1 is. And so lead 1 looks very, very negative. Does that make sense? Yeah?
Yes.
It's all directional flow based on where we have our lead placed.
Which is really always mostly true of V1 anyways. It's always negative.
It's often true of leads 1 and V1, right? Because it's all left side. Okay. You will have ST depression and or elevation, depending on which lead that we are looking in. So in leads 1 and V6, you will see significant ST depression. And in V1 and V2, you will see significant ST elevation. And it does not mean what elevation and depression typically mean. Okay? It does not mean what it typically means. Which is why on the left side, we can't tell if they're having an acute MI at the same time that they have a bundle branch block on the left side. The T waves will be broad, big, and they will be discordant.
What do you mean by broad and big? Like long along your x-axis?
Yeah, so they'll be just wider and taller than what you normally would expect them to be. Because normally we have a fast depolarization followed up by pretty much all those cells simultaneously starting their depolarization, their repolarization process, right? Now, the time of the QRS complex has widened, and also these cells start to repolarize before those as well, so that repolarization takes longer too.
Okay.
Because the timing is funky now.
And what's discordant mean?
So number 1 is that they will be big and broad, and number 2, they will be discordant, which means the T wave will always go in the opposite direction of the QRS complex. So, in the case of V1, in the case of leads 1 and V6, I have a big positive R wave, therefore what will my T wave be?
Inverted?
It will be inverted, it'll be negative. In V1, I'll have a big negative QRS complex, so my T wave will be
Positive.
And somebody in their infinite wisdom tried to liken that to the Hunchback of Notre Dame when you see it. You can try to visualize that if you want to, but basically we have a big, broad QRS, this is V1, big, broad QRS complex with a positive T wave. And they're trying to say, hey, look at the Hunchback of Notre Dame. There's his feet, here's his hunch,
Oh, perfect.
and there's his face.
Yeah, I totally see that.
Look, there's the hunchback.
If that hurts you in the visualization process, you disregard it. I don't care what you remember, but some people like to put,
And we can't call that ST elevation.
and even though the ST segment is up here, we can't call it ST elevation. In the context, we can call it ST elevation, but we can't make it mean what ST elevation normally
MI.
means.
It's not MI.
So we would say it's a left bundle branch block with ST elevation?
No, because in a left bundle branch block, ST elevation is normal.
Okay.
You almost just said possible left bundle branch block. You
Yeah,
can't-
so you can't say things like, hey, I've got a flipped T wave in lead 2, or I've got ST depression in lead 2, because that would normally be the case.
For a
in
left
bundle
bundle branch
So you can't say that. So unfortunately, when you have a left bundle branch block, there are things you cannot use the EKG to diagnose that we normally do. Right? So you have to, it's harder. You have to pay more attention to your patient's signs and symptoms, and they have to have blood work done to tell if there's cardiovascular disease processes too.
Okay.
Okay? So that's our left bundle branch to begin with. In terms of things, right? You can get a left bundle branch block in one of two ways. It doesn't really matter other than just knowing that this happens. We can have a block of the bundle itself. The bundle itself gets blocked. Or if, by whatever chance, both the anterior and posterior fascicles are blocked, then it results in the same thing. Does that make sense? If the bundle's blocked, then the fascicles may not be blocked, but they can't get the depolarization because it's not going down to them. Or if independently both of the fascicles are blocked. Maybe they had one fascicle blocked for a period of time, and then their disease process continued and it ended up blocking the other fascicle eventually because of cellular death, and now we end up with the same result. Okay?
So, Cory, maybe I'm going back a slide, but practically speaking, if I put a patient on the monitor and I see ST elevation between 2 and so I run 12 lead, then I'm trying to exclude a left bundle branch block by saying, okay, well now my QRS is wide, my T waves are discordant, so I can't call a STEMI.
You cannot call a STEMI with a left bundle branch block. That's correct.
And those are the only criteria to exclude, or to make it so that it's left bundle branch block.
The criteria to make it a left bundle branch block is
These, yeah.
monomorphic complexes in 1v6 and v1, where they're all positive there, and they're all negative in v1, and discordant T waves. Yep.
Well, it would really, really suck then if you had a left bundle branch block and ST. Or
Yes, so people that live with a left bundle branch block, and it's not a new occurrence of it, you wouldn't be able to tell if they're having a left-sided MI. That's
Would you
correct.
use your
sitting there waiting
patient
for
signs and symptoms of chest pain, diaphoretic to
Yep.
call
To deal
in?
with the transport, but you'd have to wait for the hospital itself to run its tests and stuff to determine if it's an MI and whether or not they're going to cath lab. So it's unfortunate for them because they're not going to have as rapid a treatment as you would have if you could enter into a STEMI. That's correct.
When you say monomorphic, that's different from being concordant. Concordant is just all positive or negative, but monomorphic, it's just the shape or also the amplitude. And, I mean, are they really gonna look the same?
QRS complexes can come in many different ways, right? This could be a QRS complex, right?
Mm-hmm.
That could be a QRS complex. That could be a QRS complex,
Yeah.
right? These two are polymorphic QRS complexes,
Mm-hmm.
and this is a monomorphic QRS complex because there are multiple shapes to it in these ones, and this one there's only one shape to it. So the QRS complexes in V1 and V6 are monomorphic positive waves. In V1, they're monomorphic negative waves. Period. Separate. Now the T waves are discordant to the QRS complex. So in the case of this, discordance means it's going to go in the opposite direction. So that's my T wave there. And here, that's my T wave there. Two separate things. QRS complex is monomorphic, which means it's all positive or all negative. T wave is discordant to that QRS complex.
So really, that's like the really easy way to see.
It
There's
is?
not
Derek.
Yes, that's correct.
multiple. Okay.
That's right. Good? Okay. Because we're on the left side, the complexes aren't as sharp. You notice, if you have your book open, it doesn't really matter, but when you looked at all of those right-sided bundle branch blocks, right? When you looked at them, if you look at them from a distance, for the most part, they just all look normal. It didn't look really weird. The left side is not going to be that clear because the left side has a lot more muscle mass. So the cell-to-cell transmission through the left side is going to make it look much different and more bizarre than the right side, right? When you have a right-sided bundle branch block, the majority of the heart which is the left side, was still being normal. So therefore, the QRS complex, for the most part, looked normal. But now we have the majority of the heart, the left side, that's gonna look bizarre. And because of that, we're gonna see a much different set of QRS complexes that we have here, with these big, huge, broad monomorphic waves that we see, which again are all negative in V1 and all positive in leads 1 and V6. So we're looking at the same leads, sorry. Oh, that doesn't matter, yes. Right? So leads 1 and V6, which are right here, are seeing a whole bunch of positive action traveling towards it. They don't really see anything on the right side because that's all covered up. So they're all positive because it's cell to cell. They're big, broad, and wide. 1 and V6. V1, which is hanging out right here on the person, sees the same thing, but it's all going away from it. So it's mostly negative. Aside from this little blip right here, V1 will still be a little r, big S wave, because we do see the right side, which is still being normal, which is that little piece right there that we see to begin with, followed up by a big, huge
Hunchback Notre Dame.
name. Yeah, if you want to think of it that way, then you will. So we look at the exact same leads. So what kind of rhythm do we have to have first?
Supraventricular.
Supraventricular. The
Wide.
QRS complex has to be wide. Then we look at the same leads, look at V1, or look at lead 1 and V6 first. They should all be positive with a negative flip T wave,
Monomorphic.
all monomorphic. And V1 should be monomorphic negative with an upright T wave. Make sense? And we have that. Hey, go back to that, your packet for just a minute,
Boom.
just for fun. And just for fun, look at number 2.
Whoa. Look how wide that
Is
is.
it supraventricular?
Yeah.
Yeah. PP.
Does it have a wide QRS?
Yeah. In all
Look at
leads.
1 and V6. In leads 1 and V6, do you have a weird all positive wave?
Yes.
Yes.
Look at V1. Do you have a weird all negative wave
Yes.
with a positive T wave?
Yes.
To make it look like that hunchback thing?
Yes.
Guess what you have?
And you can still have.
So these are
Noah is,
P waves?
Noah is not done with paramedic school.
Did you say right-sided, Noah?
Everybody say goodbye to Noah.
Someone's-
I know, it's been great.
Bye, Noah.
And you can. So you can still have rabbit ears with a left-sided, but it's all monomorphic.
We'll help you next year.
Yes, we might have some hitches
Like-
and stuff for other reasons.
V6 has kind of double R there, but.
Yes. All right, just for fun, take a look at number 8. Take a look at number 8.
Wide.
We have a couple
Absolutely.
things to talk about on number 8. First thing, is it supraventricular?
Yes,
Name.
Do you have a wide QRS?
yes.
Yes.
Look at leads 1 and V6. Are they all positive?
Yes.
With a flip T wave?
Yes.
Yes.
Look at V1, is it all negative?
Yes.
Yes.
With a positive T wave?
Yes.
Guess what you have?
Left bundle branch block.
What is that? Okay, now just for kicks on this one, just for fun, isolate, try to cover up, and isolate and just look at ABL.
On which one? 8?
Look at it on number 8. Just try to look at ABL for a minute.
You got a
What rhythm?
R.
If ABL were the only thing that you were looking at, and we hadn't just gone through the analysis we just did, what might you have called ABL?
Ventricular.
You might have called it a ventricular rhythm, right? Because you really have a hard time seeing P waves
Yeah.
in ABL right now. This right here is one of the benefits of a 12 lead, right? Because you might have called that an idioventricular rhythm or an accelerated idioventricular rhythm, and that would have been very incorrect. Because this person definitely has a supraventricular rhythm, right?
If you look.
With this bundle branch block. But a left-sided bundle branch block can screw up your from a distance look at something. So from a distance, if you look at this 12 lead, number 8, from a distance you look at this 12 lead, like you flash it in front of you, it's running across your monitor, and depending on which lead you're looking in, you might look at that and think that this person is in a ventricular rhythm of some sort, right? If they've got a sympathetic nervous system activation at the same time, so you've got a tachycardia, you might be calling this a VTAC, when in fact it is absolutely not. Does that make sense? So left bundle branch blocks can make our analysis a little bit more difficult. And because of that, it might make our treatment scheme a little bit more difficult to come up with.
Do these usually have like the crazy amplitudes in the precordial leads where it's like, it's almost
Yes.
going into the next?
Yeah, you might see all kinds of weird amplitude changes and stuff. And why is that?
Because it's
there's
all
more
hidden.
electrical
Because you got more average electrical activity happening than what should be happening, right? Y'all understand what Andrew just asked?
Yeah.
Right? You might see weird amplitudes in those precordial leads because you have more electrical activity on average taking place on that precordial side. So therefore you see larger amplitudes than maybe you would normally see.
Because of the cell to cell?
Because it's going cell to cell. So the average time that you have electrical activity happening over there is greater,
Okay.
right? So, things to consider. Just for kicks, let's look at number 12.
Wide. Operating one.
Few
One,
words?
Now, this is
six.
an interesting one. Look at number 12. First of all, it's supraventricular.
Right here, consume few
What
words.
lead helps you to know that it's supraventricular?
Lead 2.
Okay, lead 2 does. What other lead might show it?
AVL a little bit, tiny
An
bit.
AVL. Yeah, the very lead that we just, in the last one, looked at to say, this is ridiculous, if that's what you saw, is the very lead that we would want to look in here, right? I know that we often look in lead 2, and everybody likes lead 2, but they like lead 2 because that's what they were exposed to first, right? You guys were all exposed to lead 2 first. But lead 2 isn't always the best lead for you to look in. You need to be open-minded and judicious about what lead you might be looking at. So for this particular patient, having seen AVL first would have been a benefit to you because it would have steered you down the supraventricular path
Yes.
faster than if you'd been looking in lead 2. Does that make sense?
Mhm.
That's my plug for you, just to try to wash away your preconceived notions that one lead is the only thing you should be looking at, even though it's the lead that our monitors often set in, right? Remember that your monitors can often look in 2 or 3 leads at the same time, so have
This
more
one's
leads
gnarly.
displayed. Okay, so is this a wide QRS complex?
Yeah.
Yeah.
Is it supraventricular?
Yes.
Leads 1 and V6, are they all positive?
Yes.
Do they have discordant T waves? In lead V1, is it all negative? Does it have a positive T wave?
Yes.
So therefore we have what?
Left bundle branch.
We have a left bone. Yes?
Yep.
Yay! Isn't that fun? Okay. That's how you side the bundle branch blocks. Right side and left side. Fantastic. Unfortunately, the left side very rarely has that by itself. So I suppose, yeah, go ahead.
If you had a left and a right, would you even see any info for the right? Because the left is taking so much of the electrical activity.
Okay.
It's just gonna hide the right.
So the question becomes, what happens if you see both criteria?
And then we go to the next.
So sometimes you see criteria of both, but not all the criteria of both. So sometimes you'll see, maybe you'll see a big, broad, negative wave in V1, which would lead you down the path of a left bundle branch block, but you see clear, good, slurred S waves in leads 1 and V6, for which shouldn't have S waves to begin with, because they're supposed to be all positive, right? Well, that creates a little bit of a problem, doesn't it?
Doesn't lead 1 on 12 look like a slurred S wave?
I don't know. I'm not. Number 12, the one we just looked at, you mean?
Yeah.
I was gonna say 16.
What is that?
That's an R and R prime.
No, he's asking, he's looking at number 12 and look at lead 1, and he's trying to suggest that maybe there's a big slurred S wave there. What is that? That's the T wave,
Oh, because it's inverted.
because it's inverted down, that's right.
Yeah.
So sometimes we will have criteria of both, but not the criteria of either completed. And that leads us down a different path, where we start talking about interventricular conduction delays. Come back for another class, and we'll discuss those.
Mic drop.
Okay, so on the midterm, when it comes to EKG, no, bundle branch blocks will not be on there. Yes, axis will. No, bundle branch won't. Yes, axis will. And I might make a suggestion to you on EKG from here on out. I think that you should be doing, give or take, 7 to 10 different strips every single day. You should be going through and analyzing 7 to 10 different strips every single day. And it doesn't even matter if you reanalyze some that are already in there.
Are you gonna post,
A key. I will post a key. But you should be doing 7 to 10 analyses every day to make sure that you're in the practice of this.
Do you remember in first term when you said that at the end of the first term you would release the answers to all the quizzes?
I did not say that. I said that that the quizzes will definitely have the answers that I'll release at some time, but not necessarily at the end of first term.
I thought it was
Because you can still
before
take those.
second term that we could actually like see what the correct answers were. No? Oh, at
I'll
some-
release them at some point in time, but
Okay.
the time that you are still in the process of taking those, they will be released. Because once they get released across the board
Yeah,
for all of them. So you can't use them for
the ones that we've already done from the last term.
because it's all, it goes through the entire process and does all of
Okay.
them.
All right.
So yes, you can answer.
Right now.
Quiz tomorrow or Thursday?
Thursday.
You know what time it is?
1:30.
It's not
Chicken time?
it's
Sure,
good
I'll get a chicken.
Right?